So far, we described the HIV life cycle and mechanism of action of antiretroviral agents. We looked at HIV patients and what the DHHS guideline recommends for their therapy. We ensured adherence to ART is optimized. Now, given an HIV patient, design an individualized monitoring plan.
So here are some definitions that are important. So virologic suppression basically means RNA level below the lower limit of detection. So because our assays basically, if the level goes to zero, our assays cannot detect it. There's only uh, you know the so in most clinical trials, the assays basically cannot detect anything less than 50 copies per ml. So if it's less than 50 copies per ml, it will just say undetectable. With the latest assays that we have, the lowest number I've seen is 20. So it depends on the assay you're using. So if it's so, let's say the level is 10, um, and the assay cannot detect anything less than 20, we'll say undetectable. And if it's undetectable, we basically call it virologic suppression. Now, if somebody's viral level couldn't be lowered to actually less than 200, we call it virologic failure. Because if it does go less than 200 but still detectable, we call it low-level viremia. So suppression is undetectable. If it's between undetectable and 200, we call it low-level viremia, and if it's greater than 200, we call it virologic failure. Now, incomplete virologic response basically means if the level is still greater than 200 after 24 weeks. And that's because with the current treatments, typically with 24 weeks of treatment, you are going to achieve virologic suppression. So if somebody is still at 200 or higher at 24 weeks, and like let's say weeks later they become suppressed, they call it incomplete virologic response because within 24 weeks, you would suspect to see virologic suppression. Now, in an uninfected person, CD4 count is typically 800 to 1200, which is 40% of the lymphocytes. Once somebody gets HIV, then it would be something between 200 to 500 something, but it gradually goes down from this normal range. And of course, by definition, if someone has AIDS, it will be less than 200 or less than 14%. So the question is, what happens once we actually initiate ART? So for the viral load, in the first month we should suspect to see a 2 log drop, and 2 log drop means the way logs work is that you basically divide by 10. So if the viral load goes from 1,000 to 100, we call it the 1 log drop. So you just drop a zero. But if it goes from 1,000 to 10, that's a 2 log drop. You just drop two zeros, or divide by 10 two times. And then 3 to 5 months later, which is that 12 to 48 weeks, you will suspect to see undetectable viral load. And then in the first year of treatment, you should see the CD4 to go up by something between 150 to 250, and then beyond 2 years it levels out. So whatever gains of CD4 you get, after 2 years of treatment, it's gonna plateau, and it's not really going to you're not going to see significant increases beyond that. So let's say if somebody's CD4 is 300 and you treat, 2 years later it may be, like around 500, 550. So 10 years from now it will still be around 550. You're not going to see significant increases beyond this. So goal of therapy is for the viral low, so the RNA to be undetectable, and we would like to maintain a CD4 count of at least 500, which may not be achievable in every patient. Let's look at some monitoring parameters. So basically, these are from the guideline. At baseline, before starting, they want everyone to check CD4 count, HIV viral load, ideally HIV resistant testing, so that when you choose a regimen, you choose something that's susceptible. You also want to make sure you find out if the patient has Hep C and Hep B co-infection. Of course, basic chemistries, so Chem7 to assess the renal function. You need the liver function test, which should really be called the liver chemistries. Just some of these regimens are can affect these numbers. So for monitoring, you need a baseline value. So if something is causing increase in liver chemistries, then you want to know what their baseline was. Complete blood count with the differential, so that will also tell you the number of lymphocytes. Fasting lipid panel, because HIV patients are at increased risk of cardiovascular disease, so you want a baseline lipid panel in order to assess their risk for cardiovascular disease and how to manage. Fasting glucose, since they are already at increased risk of cardiovascular disease and death, you want to also assess their um, glucose and make sure they don't have diabetes. And of course, if above caviar, you want to check for HLA-B5701 polymorphism. And urinalysis for assessment of renal function. If the patient is taking tenofovir, well, I mean, you do that baseline for everyone, but if you do it every 6 months if they are taking tenofovir. One thing that's important, so once you start treatment, you want to check CD4 counts, every 3 to 6 months, and then eventually every 12 months. With the viral load, you do it every 3 to 6 months, only after they become undetectable. Until they become undetectable, you're not gonna wait 3 weeks. So you should do it every 2 to 8 weeks until they're undetectable. Once they're undetectable, then you do every 3 to 6 weeks, and then as they maintain suppressed viral loads, then you go back to every 6 months. Let's see what else. So those are basically the important, CD4 and HIV viral load are the important monitoring, the most important monitoring when it comes to HIV patients.